All right, in this little lecture, we're just going to do a review of different types of heart blocks. So I always use the poem when teaching people how to learn heart blocks. So the poem goes like this, and you can Google this. If you just Google heart block poem, it should show up. So the first line of the poem reads, "If the R is far from P, then you have a first degree. Longer, longer, longer drop, then you have a Winky Bach." Winky Bach, remembers, are second degree type 1 heart blocks. If some P's don't get through, then you have a Mobitz 2. Mobitz 2 is another word for second degree type 2 heart blocks. If P's and Q's don't agree, then you have a third degree or complete heart block. So let's talk about what's happening in each type of heart block. So looking at a first degree heart block, there's some kind of delay in conduction from the SA node to the AV node. So our conduction can be delayed for multiple reasons. Could be idiopathic, meaning we don't really know why. It could be that they're on heart medications that cause this conduction delay. Or it could be something like heart disease. But typically this is asymptomatic. People may not even realize that they have this type of heart block, and they're just living with it because it typically doesn't cause any symptoms. First degree heart blocks are the only heart blocks where we label the underlying rhythm. For example, if I was looking at this rhythm right here, it would be a sinus rhythm at however many beats per minute with a first degree heart block. And we'll practice that in the practice strips. With your second degree heart block, you have two types. So you have a second degree heart block type 1. This is also called a Mobitz 1 or a Winky Bach. Now you still have to label it second degree heart block, but you can either write second degree heart block type 1, second degree heart block Mobitz 1, or second degree heart block Winky Bach. So it has all different kinds of names, and you can choose whichever one you want. I always just call it type 1 or type 2. I think it's the easiest. What happens with a type 1 is that the conduction gets delayed, and it's going to keep getting delayed till eventually it's blocked. So when we're looking at the rhythm down here, and I'm looking at my PR interval, so my P wave to my QRS, it gets longer and longer until finally the beat gets dropped. So longer, longer, longer drop, then you have a Winky Bach. These are typically slightly bradycardic, but may not be bradycardic at all. It just depends on your patient. So the patient could either be symptomatic or asymptomatic. Causes of this are commonly heart disease or some kind of cardiac ischemia or some kind of cardiac injury. There's also a second degree type 2. And in a second degree type 2, we just have blocked conductions. So we'll just look at this section. So second degree heart block type 2. It's also called a Mobitz 2. And also called a classic heart block. So remember, you still need to label it a second degree heart block, but you can call it a second degree heart block type 2, second degree heart block Mobitz 2, or second degree heart block classic. The way that I remember this is that there's two S's in classic, and it's a type 2. So that's how I keep that straight. With a second degree type 2 heart block, we have some blocked conductions. So not all of my conductions held in the atrium from the SA node are going to get through. And we can either get a consistent conduction ratio, so I may have 2 P waves for every QRS or 3 P waves for every QRS, or it might be a variable conduction ratio where sometimes I have 2 P waves for a QRS, sometimes 1, sometimes 3, or maybe it can just be all over the place. These patients are typically a little bit more symptomatic because they are probably going to be more bradycardic. Now with a second degree type 2, our QRS complexes may be narrow, meaning that the conduction delay is somewhere higher above the bundle of His or at the level of the AV node, or they can be very wide. And that just means our conduction delay is below the AV node, maybe down in the bundle branches or down below the bundle of His. But it can be narrow or wide, so don't base it just on the QRS complex. And then if we look at a complete heart block, there's a complete block somewhere in the conduction system. It's either going to happen at the level of the AV node, or it's going to happen further down, kind of like our second degree type 2s. So if it's higher up here, I'm going to have some narrow QRSs. If it's lower down below the bundle of His, I'm going to have some wider QRSs. With these patients, the atria and the ventricle are running on their completely own intrinsic rates. So you can see here, if I circle all my P waves march out at a pretty consistent rate. There's probably one hidden in this QRS complex. But if I look at all my P waves, they all march out equally. All of my RRs, intervals, also march out equally. So my atria, which is represented by the P's, my SA node, is beating at its own intrinsic rate, and my ventricles, represented by the QRS, is beating at its own intrinsic rate. There is no communication between the two. And again, I may have a narrow QRS or a wide QRS. These patients can range anywhere from stable to unstable. Typically, I would say they're more on the unstable side because they tend to be bradycardic. The wider the QRS complex, the more bradycardic that they're probably going to be. And we would treat this just like a bradycardia algorithm patient. Causes of this could be idiopathic, some type of heart disease, some kind of problem with their conduction system, or it could be something more serious like a myocardial infarction. But if we look here, we can see that my PR intervals are all over the place. There's no relationship between the P waves and the QRSs. So let's look at some examples. I'm going to start off by just circling all of our P waves in red. So when I start labeling heart blocks, I start at the beginning. Start with a first degree and work your way up to third degree. So I'm going to look at this rhythm. Could it be a first degree heart block? Well, I do have some PR intervals that are not long. Remember, with a first degree heart block, we have that delay from the SA to the AV node. That gives us a long PR interval, so it has to have that long PR interval. These are typically regular rhythms too, and this rhythm is very irregular. My heart rate up here does say 63. Now let's take a look at all of our PR intervals. So we looked at this one, and it was pretty short. The next one gets a little bit longer, and then I have a really long PR interval, and then it seems I have some type of dropped beat. And then I go back to a short interval, a medium interval, and then a long interval. So if I look at my PR intervals here, it looks like they're getting longer and longer. So could it be a second degree type 1? Longer, longer, longer drop, then you have a Winky Bach. Yes, it does fit that category. So we're going to label this rhythm second degree heart block type 1 at 63 beats per minute. And my rate was given there in the monitor strip. Uh-oh. See if we can get that to stay. All right, let's take a look at our second example. And I'm going to go through and I'm going to circle all of our P waves here. So this rhythm is regular. So can't be a second degree type 1 because those are irregular. So let's start at the top with first degree. And let's take a look at my PR interval. I like this one. It ends right on a bold line, so it's easy to see. And here's where the P wave starts. So I have 5, 6, 7 small blocks for my PR interval. I know that a normal PR interval is only 0.12 to 0.2 seconds. So this one's actually 0.28 seconds because it's 7 small blocks, and every small block, remember, is 0.04 seconds. So this is very long. And all my PR intervals are the same just by eyeballing them. I don't even need to measure them out. They all look pretty much the same. So this already falls within that first degree heart block category. Now remember, with first degree heart blocks, it's the only heart block where we need to label the underlying rhythm. So let's just take a look at the underlying rhythm. I do have a P wave for every QRS. My QRS is narrow, and I have a T wave, so it is a sinus rhythm. Looks like my rate is a little low though, at only 50 beats per minute, so it's going to be sinus bradycardia. So I'm just going to abbreviate that by writing SB at 50 beats per minute, and that's because it's below the normal intrinsic rate of the SA node, which is 60 to 100. And next I need to look at my ST segment. So I'm going to draw my isoelectric line here. And it looks like I do have some ST elevation. If I look at the J point on this QRS, it does fall 2 blocks above that isoelectric line. So I got sinus brady at 50 beats per minute with ST elevation for my underlying rhythm, and I have a first degree heart block. So that's how we're going to label that one. And with that ST elevation, I'd be worried about this patient having an MI. So it could be that they have the first degree heart block because of a medication they take, but it also could be caused by that myocardial injury from the heart attack. All right, let's take a look at our next one. I'm going to be looking at lead 2, which is up here. This is just a different lead, but we'll look at the first one because we always look at lead 2 for a reference, and I'm going to circle all my P waves. All right, so I've got all my P waves circled. So let's just start at the beginning when we're trying to figure out a heart block. I'm looking at this and I'm kind of deciding right away, well, I think it's a heart block because it looks like I have more P's than QRS's. So that kind of signals a heart block. So let's start all the way with first degree. Do I have a long PR interval? Well, my PR interval is actually right, probably normal, like high side or normal, 0.2 seconds, but it's not long. And I have more P's than QRS's, so it can't be a first degree. Could it be a second degree type 1? Do I have a longer PR interval? No, all my PR intervals look pretty consistent. If I measure out all these PRIs, they all look pretty much the same. Could it be a second degree type 2? If some P's don't get through, then you have a Mobitz 2. Well, yes, that does fall into that category. So I'm going to stop right there. I'm not even going to get to third degree. We're going to label this a second degree type 2 heart block. I need to figure out my rate. Let me get out my calculator. All right, so I'm going to count blocks in between. I'm just going to go during my long sections because that seems to be more regular than this short section right here. But I've got 5, 10, 15, 20, 25, 30, 31, 32, 33, 34, 35. So 1,500 divided by 35 gives me a rate of 42.8, so we'll round that to 43. 43 beats per minute. So second degree type 2 heart block at 43 beats per minute. Now for my second degree type 2s, I do need to put a conduction ratio, remember. Now if I was only looking at this section of the strip, I would call this a 2-to-1 conduction ratio. But because it does change in the whole strip, I have one where I only have one P wave for QRS, it's going to be a variable conduction ratio. So we'll just write with variable. Variable conduction. Second degree type 2 heart block at 43 beats per minute with a variable conduction. Now a lot of people look at this and they'll say, well, why isn't it third degree? Because really, let me switch colors here. If I marched out all my P waves, all my PP intervals do seem regular. And then all of my, besides this one, all of my RR waves do seem regular. The reason it could not be a third degree is because all of our PR intervals are consistent. So there is still some communication there between the atria and the ventricles. And even though some of these PPs and RRs march out, we do have that consistent PRI. And when there's a consistent PRI, then it cannot be a third degree complete heart block. All right, this one we don't really have any small boxes because of copy, but it does give us a heart rate of 38. Go ahead and circle all of our P waves. There's a notch there, there's a notch in there. And let's go through and see if we can label this one. So starting again at the beginning at first degree. Could it be a first degree? No, I've got some PR intervals like this one, this first one, where it's pretty close. Could it be a second degree type 2? Well, my rhythm's regular, and it has to be irregular to be a second degree type 1 is what we're going to talk about first. Could it be a second degree type 1? Well, my rhythm is regular, and a second degree type 1 would be irregular because I have that longer, and then dropped beat with that elongating PR interval. Plus, my PR intervals don't really seem to get longer. That seems like there's really no pattern to any of my PRIs. So it cannot be a second degree type 1. Could it be a second degree type 2? Well, I do have more P's than QRS complexes, so that does fall in with second degree type 2. However, my PR intervals are all over the place. And remember with the second degree type 2, when a QRS does follow a P wave, that PR interval is going to be consistent. So it cannot be a second degree type 2. Could it be a third degree? Well, if I measure out all my PPs, it looks like they measure out pretty regularly, so my SA node is doing its own thing. And if I measure out all of my RR intervals, if I took my sheet of paper and made my little notches and moved them along the rhythm, it does look like those march out too. So this is going to be a complete heart block. At 38 beats per minute. And for complete heart blocks, we don't need to put conduction ratios because they're typically always going to be variable. So if we look between these two QRSs, I only have 2. With this one I have like 2.5. With this one I have 3. Then I go back to 2. So it's always going to be variable with a complete heart block, so there's no need to put a conduction ratio. So it's just going to be a complete heart block at 38 beats per minute. Now the pulse is 38, so this patient's probably a little bit symptomatic, but their blood pressure is actually pretty good, and their QRS is actually pretty narrow, meaning that the block is more towards the AV node and not below the bundle of His. So this patient probably not going to be as symptomatic as someone with a more severe heart block. All right, next one. Again, we're going to circle all of our P waves. All right, my heart rate here is 30 beats per minute. So it got cut off there, but that's what's telling you there's a heart rate, 30 beats per minute. So already thinking it's pretty slow. My QRSs are narrow, but I got inverted T waves and they look a little goofy, so probably going to be a sick heart. So let's figure out what type of heart block it is. I'm already thinking heart block because I see that there's more P's than QRSs, and that signals heart block to me. Could it be a first degree? Well, my PR interval is a little bit long, but I have more P's than QRSs, so it can't be a first degree. Could it be a second degree type 2? Well, my PR intervals, just did a bad job drawing them, but all my PR intervals actually look the same. They don't seem to get longer. Even though it is irregular, my PR intervals do appear to be the same. Could it be a second degree type 2? Remember, second degree type 2s can be regular or irregular. It just depends on whether it has a consistent conduction ratio or a variable conduction ratio. Well, I have more P's than QRSs, but my PR interval looks to remain pretty consistent when I have a QRS following my P wave. So this does fall in line with a second degree type 2. Now, since this is second degree type 2, this is the only one where I have to put a conduction ratio. And since I have 2 P waves for QRS here, 1 here, 2, and then 1, even though it's a pattern, it is a variable conduction ratio. So with variable conduction. And since this patient's only 30 beats per minute, I imagine that they're pretty sick. This was actually a patient of mine, and they had a PE. So this was probably brought on by hypoxia, this heart block, and just all of that ischemia, that lack of oxygen getting to the heart because they had a PE, so they weren't getting good oxygenation. All right, this one has a little bit of artifact, and that's just because the patient, it was cold outside. I actually remember this patient. It was cold outside and she was shivering a little bit. But I do have a heart rate up here. It's 42 beats per minute. So I'm already thinking it's kind of slow. And let's go ahead and circle my P waves. So this is a 12 lead, all right? So it's we're showing 12 different areas of the heart. So our P waves and our QRSs may change morphology a little bit as we're going through. I'm going to look at this bottom line down here because for me it looks like it has the least amount of artifact, and I can pick out these P waves pretty well. So there's all my P waves. I'll circle my QRSs here. So more P waves than QRSs, so I'm definitely thinking heart block already. Plus they're bradycardic, which kind of goes with most of our heart blocks. All right, so let's see what we got here. Could it be a first degree? Well, I have more P waves than QRSs, so it could not be a first degree. Could it be a second degree type 1? Well, my PR interval does not get longer and longer. Highlight those PR intervals here. In fact, they look to remain pretty consistent when I do have a QRS following a P wave. So it cannot be a second degree type 1. Plus this rhythm looks very regular. So it's not irregular. So that also does not fall within that category. Could it be a second degree type 2? Well, I have more P's than QRSs, which does fall in line with a second degree type 2. And my PR interval remains consistent when I have a QRS that follows the P wave. So that does fall in line with a second degree type 2. So we're going to stop right there so we don't talk ourselves into a third degree, and we'll talk about that in a minute. So second degree type 2 heart block. I got my heart rate 42 beats per minute. And I need to put a conduction ratio, and this one is pretty consistent. I have 2 P waves for every QRS. So we just write a 2:1 for our conduction ratio. So second degree type 2 heart block at 42 beats per minute with a 2:1 conduction ratio. Now the reason I said we're not going to talk ourselves into a third degree is because a lot of people look at this and they look at these PP intervals and they say, well, that marches out pretty consistently. And then they look at the RR intervals. Let me switch colors. And they're like, well, that marches out pretty consistently too. So I have my SA node going at its normal intrinsic rate and my QRS and my ventricles going at its normal intrinsic rate. So a lot of people want to go ahead and call this a third degree. And that's why we do that method where we start at the beginning and we work our way from first degree to third degree, because it fit at second degree type 2. So we're going to stop there. Don't even start thinking about third degree if it fits that second degree type 2 category. And what makes this not a third degree heart block is that PR interval, when a P wave does follow a QRS, remains consistent. So there is still some relationship between the atria and the ventricles. What's just happening, if this is my heart, and here's my SA node, and here's my AV node, every second one is getting through. So one doesn't get through, it's blocked. The second one does get through the AV node down to the ventricles. All right, second impulse comes through, it gets blocked. Third impulse does get through, goes down to the ventricles. So every other impulse from the SA node is just being blocked. And that's what's causing that 2:1 conduction ratio. All right, let's take a look at this one now. I don't have any blocks here to count my rate, so I'm going to guess. I'm going to call this about 30 beats per minute just because it looks pretty slow. But I don't have any blocks there to give me a reference. So, all All right, let's circle all of our P waves. There's probably a P wave in here because that T wave looks a little funny. Probably one in here, but we can't really see them. Actually, yeah, let me start that over. We're only going to mark the ones that we can see really well, because now that I look at it, all those T waves do look the same, so I don't think there's P waves hidden in there. And it looks like we had a little bit of artifact here. It looks like the patient took a breath and maybe caused our isoelectric line to move a little bit. All right, now let's go through and circle all of our QRSs. So again, already thinking heart block, not just because this is a heart block review, but because I have more P waves than QRSs. So let's start at the beginning. Could this be a first degree? Well, my PR interval actually doesn't look that long, and I know we don't have any blocks for reference, but just glancing at it, it looks pretty normal. Plus, I have more P waves than QRSs, so it could not be a first degree heart block. Could it be a second degree type 1, a Winky Bach, longer drop? Well, my PR intervals all look consistent, so they're not getting longer and longer and dropping. They all look pretty much the same. So it cannot be a second degree type 1. Could it be a second degree type 2? Well, I have more P waves than QRSs, so that does fall within the second degree type 2 category. And most importantly, my PR intervals when a P wave or a QR follows a P wave is consistent. So that does fall in line with a second degree type 2. And we decided it was at 30 beats per minute. Remember, we're counting the ventricular rate for our actual heart rate because that's what's producing a pulse. And with my second degree type 2, I have to put a conduction ratio. I have 3 P waves for every QRS. Now, could there be a P wave hidden in this T wave? There could be, but I can't really pick it out. I can't really see it, so I'm not going to include it in my conduction ratio. So second degree type 2 heart block at 30 beats per minute with a 3:1 conduction ratio. The reason this cannot be a third degree heart block is because the PR interval remains consistent when we do have that QRS following that P wave. So there is still some relationship between the atrium and the ventricle. What's happening here is that 2 impulses sent out by the SA node are being blocked. They're not being sent all the way through the conduction system. And seeing as this QRS is a little wide, my block is probably below the AV node, but every third one is getting through and conducting a pulse. So I have 2 blocked and then 1 gets through, 2 blocked and then 1 gets through. And that's what gives us our 3:1 conduction ratio. All right, take a look at our next one. So I do have a pulse rate of 48. It's low. Probably not going to be as symptomatic as 30, but it is pretty low. I can see my P waves here. So they're a little small, but they are there. So I'm going to go ahead and circle those. They stick out a little bit more. And we're going to start at the beginning. Could this be a first degree? Well, I have 1 P wave for every QRS complex. And that kind of points me in the direction of a first degree. And my PR interval is very long. I have an elongated PRI and it's consistent. It's not getting longer and longer. So we're going to stop right there at first degree. Now remember, with first degrees, we have to label the underlying rhythm. I have a P wave for every QRS. My QRS is narrow, even though we have some ST depression. So I may want to include that in my name. If we draw our isoelectric line, our J point falls well below that. My pulse rate is 48. So because I have a P wave for every QRS, this is going to be a sinus rhythm, but it's going to be sinus Brady because how slow the heart rate is. So I'm just going to abbreviate that by SB at 48 beats per minute with ST segment depression, because we do have some ST depression there, and a first degree heart block because we have that long PRI. All right, we're going to go down to the next one. I'm going to circle my P waves. And we notice something about these P waves is that they're upside down. They're inverted. So first of all, if I see inverted P waves, I'm going to make sure I'm looking at lead 2, and I am. I'm looking at lead 2 because that's where we get all of our reference from. And I'll zoom in so you can see that inverted P wave. Oh. So here's my isoelectric line, and then it dips below the isoelectric line for that P wave. So that's upside down. Zoom back out. Maybe, if it'll let me. There we go. So my P waves are inverted. So that's something we have to think about when we're going to be labeling our rhythm. All right. Heart rate, 90 beats per minute. That's pretty good. That's pretty fast. Blood pressure may be a little low. I don't really know what's going on. This wasn't my patient, so I don't know exactly what's going on with them. But let's figure out what type of heart block that we do have here. Make it a little bit bigger. All right, so let's start at the beginning with first degree. I have one P wave for every QRS complex, so that does indicate a first degree. My PR interval is long. All right, so here's a good one because this starts right on a line. I know it's hard to see. Here's another good one. So we can see that it's more than 5 blocks. It's about 6 or 7 blocks long. So my PR interval is elongated, and that falls in line with a first degree heart block. Here's another good one where we can see at the end here how long that PR interval is. But my PR interval always looks pretty consistent. I do have a little bit of variation in my heart rate, and that could just be that the patient moved because it only happens right here. Remember, these are real patients. They're not going to be textbook heart rhythms. And so I decided it's going to be first degree. It can't be a second degree type 1 because I don't have a longer drop. It can't be a second degree type 2 because I don't have more P's than Q's. And it can't be a third degree because my PR intervals all remain consistent. So it really only leaves me with a first degree heart block. And remember, with a first degree heart block, we have to label our underlying rhythm. And this one is a little bit different. I like this example because it points out how important it is to label that underlying rhythm. And just so you can kind of see that elongated PR interval a little bit better, let me zoom in here. So my P wave starts right here, and my QRS begins right here. So I have about 1, 2, 3, 4, 5, 6 blocks long. So it is a little bit elongated. My underlying rhythm, because the P waves are inverted and I am in lead 2, it's going to be a junctional rhythm. Because remember, when it comes from the AV junction, we get that retrograde conduction, and that retrograde conduction is going to cause that inverted P wave. We probably have some type of heart block just below the AV node because our QRS does look narrow, but it's borderline wide. It's probably right at 0.12. It looks like it's right at 3 blocks. So this is a first degree heart block. I have a junctional rhythm. It's at 90 beats per minute, so that's an accelerated junctional. If you have trouble labeling what type of junctional, go back to the junctional rhythm ID video. Accelerated junctional rhythm at 90 beats per minute with first degree heart block. All right, so if we look at this one, our next example here, this is a 12 lead. So luckily the way this one printed out, this is actually my 12 lead, and then it gives us 3 different leads down here to view. We're going to look just at lead 2. I just want to go back here. It does give me my heart rate, so I'm going to write that down there. Oops, to where I'm looking. It's 37 beats per minute. Let's go ahead and circle all of my P waves. All right, and then we can even circle all of our QRS complexes. Oops, it's supposed to change colors. All right, so right off the bat, I see I have more P waves than QRSs, so I'm already thinking heart block. So let's start at the beginning. Could it be a second degree, or could it be a first degree heart block? Well, my PR interval is right at, looks like 4 blocks, which is within normal for a PRI. That's 0.16 seconds. So it can't be a first degree heart block. Plus I have more P's than QRS's, so it doesn't really fall within this, the first degree heart block category. Could it be a second degree type 1? We'll start there. Well, I don't get longer and longer. My PR intervals remain pretty consistent, so it can't be a second degree type 1. Could it be a second degree type 2? Well, I have more P's than QRS's, and when a QRS does follow the P wave, my PR interval does remain consistent. All right, so I don't have PR intervals that are all over the place. So it does fall in that second degree type 2 category. So we're going to stop there. We're not going to even go on to third degree, because we figured it out. Second degree type 2 at 37 beats per minute. Remember, we do have to put a conduction ratio with our second degree types 2s. This one is regular. I can tell there's a regular conduction ratio because my rhythm is regular. I have 2 P waves for every QRS complex. So I just write that 2:1, 2 to 1 conduction ratio, 2 P waves for every QRS. So second degree type 2 at 37 beats per minute with a 2 to 1 conduction ratio. It's impossible for this to be a third degree heart block because my PR interval remains the same. So there still is communication between the atria and the ventricle. It's just that every other signal is getting blocked. All right, here's another good example of a second degree type 2, but we'll go through and do our rhythm ID. So I'm going to circle all my P waves here. And I'm just going to, I don't have the whole complexes here, so I'm going to skip that part. I'm just going to look at, oops, that was supposed to be blue. Now I can circle my QRS's. All right. So again, I have more P waves than I have QRS's. So I'm already thinking that it's going to be some type of heart block. Let's figure out our rate really quick. Got 5, 10, 15, 20, 25, 30, 35, 40 blocks in between each QRS. So 1500 divided by 40, that gives me a rate of 37.5, so we'll call that 38 beats per minute. So it is slow. My QRS looks like it's starting to get a little wide. It's still narrow. It's about 3 blocks, but it's getting there right on the line. So my wherever my heart block is, it's probably pretty close to the AV node. So could it be a first degree heart block? Well, no, my PR interval actually is pretty normal. It's 5 blocks. So I like this one because this QRS starts right on a bold line. This P wave starts right on a bold line, so it's 5 small blocks. It's 0.2 seconds. That's not a long PRI. It's on the high side of normal, but it's still within normal. Could it be a second degree type 1? Well, my PR interval remains pretty consistent throughout. It does not get longer and longer, so it cannot be a second degree type 1. Plus, this rhythm is regular. Could it be a second degree type 2? Well, remember, second degree type 2 could be regular or irregular, depending on the conduction ratio. So this one is regular. But when I have more P's than QRS's, so that does fall in line with second degree type 2, and my PR interval remains completely the same every time, so it cannot be a third degree. There's still some relationship between the P waves and the QRS. So this does fall in the second degree type 2 category. Second degree type 2 heart block at 38 beats per minute with a 2 to 1 conduction ratio. All right, so this one is giving me 3 different leads. It has lead 1, lead 5, and I'm going to look at lead 2, because that's where we always look at for a reference point. I'm going to go ahead and circle all my P waves. Looks like there's kind of one there. Looks like there's probably one buried in that QRS complex here, but I can't really see it. All right, now I'm going to circle, or I'm not going to circle, but I'll put little arrows indicating all of my QRS complexes where they are. So I'm already thinking heart block because I have more P waves than QRS's. My heart rate's up here because it's a monitor printout, so it gives me a heart rate of 42. Could it be a first degree heart block? Well, No, I have some very short PR, although I have some very long PR intervals, I also have some very short PR intervals. Plus I have more P waves than QRSs, so it cannot be a first degree heart block. Could it be a second degree type 1? Does it get longer drop? Or longer drop, or longer drop? It doesn't have to be 3 longers, just so you know. It could be an interval of 2, 3, 4, 5, whatever, longer drop. But no, that's not the case here. I have a short, then a long, then a real short, and then a medium, and then a real long. There's really just no pattern to that. It doesn't get longer and longer and then drop. Plus, this is a regular rhythm. If I look at my spikes where my RR intervals are, my QRS complexes, you can see that it marches out pretty regularly. And second degree type 1 has to be irregular because we have those drop beats. Could it be a second degree type 2? Well, I do have more P waves than QRSs, but it doesn't look like I have any consistent PR intervals. And remember, with a second degree type 2, there's still some communication between the atria and ventricle, so our PR intervals will be the same. So it could not be a second degree type 2. So this leaves us with third degree. So if I were to take my piece of paper and I mark out my PP interval and I move that down the line, looks pretty regular. Looks like all my PPs march out. And there's probably a P wave buried in this QRS complex. And then it looks like all my RRs march out. So my P waves are doing their own thing, going at their intrinsic rate, and then my ventricles, they're doing their own thing, going at their intrinsic rate. There's absolutely no communication between the P waves and the QRS complexes. My heart rate is 42. So this is going to be a complete heart block or third degree heart block, however you want to label it, at 42 beats per minute. And remember, with a complete heart block, you do not need to put a conduction ratio because it's given that it'll be pretty inconsistent. All right, this next patient, I have a series of 3 strips. That was actually a patient that I had. This patient came in for a syncopal episode. I believe we're at Cedar Point actually, passed out, had some syncope, and they came in by squad, pretty stable, pink, warm, dry. You know, good thing that this patient came in. They were fairly young. They were in their 30s, really stable. You can see the blood pressure here is good, 145/80. Pulse ox was good as 100%. So everything about this patient screamed stable, except that for some reason this patient had passed out. So hooked him up to the cardiac monitor, and then in the series of just a minute, and we'll go through this, it's actually less than a minute, so we have one strip at 17:49 and 57 seconds, 17:50, which is 3 seconds later, and then 7:50:05, which is 5 seconds later. So we're looking at like a 10-second period or 15-second period. We went through all these different types of heart blocks. So we're going to break it down. And that's what we did. We printed off the strip, and it actually took us a while to break down this patient's EKG because it was so interesting. Now, little side note, for testing purposes, I would not give you a heart block that changes back and forth between different heart blocks. That's just mean. I wouldn't do that. We're just going over this one because I find it very interesting, and it is common that a patient will change between 2 different types of heart blocks. I've seen some patients go from second degree type 1 to second degree type 2. I've also seen some patients go from second degree type 2 to third degree heart blocks and then back to second degree type 2. So it does happen sometimes that they may change between some heart blocks. Usually we see it be pretty consistent, but it is possible. So for this patient, we're just going to look at the beginning portion here. So we're going to look from the beginning to here. And let's circle all of our P waves first. Right, so the red are my P waves. The bumps before that are my T waves. And then we'll just put little arrows on our QRSs so you can see them. If it'll let me change colors, there we go. QRS, QRS, QRS. So we can see it starting to get a little irregular at the end there where it's slowing down. All right, so now I know there's some type of heart block going on because this is a real goofy rhythm, right? So I'm just going to mark my PR intervals. And this is lead 1, which is okay. We can look at lead 1. This is lead 2 down here where the PR intervals may be a little bit easier to see because my P waves are a little bit bigger. So I'll mark them down there as well. And so when we are just looking at this section, I notice that my PR intervals start getting longer. So I have a longer drop. It's just a big series. It's not 2 or 3 where it gets longer then drops. I have 1, 2, 3, 4, 5, 6 beats until I get that dropped beat. So it's like a longer then drop. But that's consistent with a Winky Bach. So that's a 2nd degree type 1 heart block. I'm going to write it in red just so it shows up really well. And, you know, she had a pretty good heart rate. So we'll just put 97 beats per minute. So she starts off in a 2nd degree type 1. Then this happens. So if we're just looking from here to here, what do we call that? Think back to our asystole lecture. This is a type of asystole, essentially. It's called a ventricular standstill. Now, mind you, the patient is still awake. Now, this is only about 3 seconds, but there's 3 seconds where, I mean, basically her heart's not beating because I don't have any QRS complexes, which means the ventricles aren't beating at all. So she's technically in asystole for about 3 to 4 seconds, which is pretty crazy. So this is probably what caused the patient to pass out. She probably had one that was a little bit longer. Her cardiac output dropped, and so she passed out, and it kind of kicked in her heart rate again. So we have a 2nd degree type 1, but then a ventricular standstill. So now let's just look at this next section because this is from up there. So this is that ventricular standstill that we just saw. All right, I'm going to look at lead 2. I'm going to circle my P waves. All right, so we only have from here to here to look at because this is kind of cut off here. But I've got my P waves there in red. I'm going to put arrows down on my QRS complexes so they stick out. And let's look at our PR intervals. So this one is about 10 blocks. This one is about 1, 2, 3, 8, and this one is also 10 blocks. So they are consistent. So I have more P's than QRS's. I don't have a longer drop anymore, but my PR interval is consistent. They're both 10 blocks long. Even though they're long, they are consistent. So now I have a 2nd degree type 2. And I don't know what her heart rate was at this point. I'm sure it wasn't no longer 97 beats per minute, but I put it at whatever beats per minute that equaled out to. It looks pretty far apart. 5, 10, 15, 20, 25, 30, 35, 40, 45. Yeah, we're looking at like 30, 35 beats per minute there. So we'll just stick a 35 in there. And I have a variable conduction ratio. So here I only have 2 P waves. This one I have 3 P waves. Oh, I'm going to run out of room. So variable conduction. So that's the second part. So that part ended about right here. All right, so that's the strip that we kind of just looked at. Now let's look at this last part. Circle all my P waves. Looking at lead 2 again. And it looks like we stay in that 2nd degree type 2, right? But now we have a more regular conduction ratio. Looks like I have 2 P waves for every QRS complex. Let's see what my rate is now, 5, 10, 15, 20, 25, 30, 35. So it's a little higher, probably around 40 beats per minute. With a 2-to-1 conduction ratio. So in just that 15 seconds, so much happened with that patient. And actually, I forgot, there is more. If we just look at this section, so this is 2 different sections here. Oops, oh my gosh, my computer's freaking out. All right, so we're gonna look at this block. I thought it was a continuation of the strip before, but this one is different. Circle all my P waves. I thought there was a 3rd degree heart block in here somewhere. Look at my QRS complexes. I have more P's than QRS's. It's not a longer drop because it is regular there, but my PR interval's all over the place. So this is a 3rd degree or complete heart block. At 5, 10, 15, 20, 25, 30, 35, 40, about 40 to 45, so we'll just call it 30 beats per minute. So in 15 seconds, just to review this. Patient comes in for syncopal episode, hook them up to the cardiac monitor. They begin in a 2nd degree type 1. We get that longer drop. So longer drop, then you have a Winky Bach. We can see that down here with these PR intervals getting longer and longer. 2nd degree heart block type 1 goes into a ventricular standstill where they essentially don't have a pulse, and she was awake and talking that whole time. That was a continuation of that ventricular standstill. Go into a 2nd degree type 2 heart block with a variable conduction ratio. Then into a 3rd degree complete heart block because my PR interval is no longer consistent. Back into a 2nd degree type 2 heart block, but this time with a regular conduction ratio of 2 to 1. So crazy how much could happen in just 15 seconds, and we really had to sit down and look at this and kind of take it apart piece by piece to really figure out what's going on with this patient. What happened to this patient was she was really young. She was in her 30s. She got admitted to the hospital to have a pacemaker implanted. And what that pacemaker will do will ensure that, if she falls into one of these 2nd degree type 2 or 3rd degree heart blocks, that it'll start pacing her heart for her. So she doesn't get bradycardic or possibly go into that ventricular standstill and pass out, possibly, go into a cardiac arrest. But I thought it was a real cool patient. That's why I want to show that example. Kind of shows all those different types of heart blocks besides the 1st degree all in one strip, which is kind of cool.